Good morning, everyone. Welcome to our Wednesday meeting. It's a pleasure for us to introduce Dr. Karabo Mahuma. She's a dedicated and passionate chemical pathologist currently serving as part of the dynamic team in the PathCare team. Her journey in medicine began at the University of Pretoria when she obtained her medical degree in 2014. Following this, she completed her internship in community service in Limpopo and experienced the nurtured her understanding and deep respect for the complexities and resource challenges of healthcare delivery in rural settings. As a medical officer, her interest in laboratory diagnostics later propelled her to obtain a specialist qualification from the Colleges of Medicine of South Africa in 2023. Followed by completion of an Mmed from the University of Pretoria in 2024. She remains enthusiastic about bridging the gap between clinicians and laboratory personnel in pursuit of quality healthcare for all patients. Our topic is the silent drop, an overview of hypophoshataemia in adults. Thank you, Karabo.
Thank you so much for the kind introduction. Good morning, everyone. So the title of my talk, as said, is the silent drop. And the reason why I chose this is we see so many patients, especially our hospitalized patients, that present with hypophoshataemia and sometimes can be underlooked or something that people may not really have an idea how to investigate further. So hopefully the talk will help with that a little bit. So just overview of my talk, so a brief introduction, looking into the impact of this electrolyte imbalance, looking at some physiology and looking at various causes and clinical presentation of how these patients may present, and just an overview of approach to investigation, and lastly, a treatment overview. So just introduction to dietary sources of phosphate, just to name a few: milk, cereal, grains, fish, poultry, eggs, meat, and peanuts, all give us our dietary source of phosphate. And in the body, phosphate or inorganic phosphate exists freely, not bound to anything, at 85% that is free in these complexes or in these compounds, and then 10% bound to plasma proteins, with 5% complex to calcium, magnesium, and sodium. So what we measure is obviously the free bioactive form of phosphate. So what is the importance of phosphate in the body? Just an overview, most of it we know, but it forms an important part of cell membranes through the phospholipid bilayer, and as well as ribonucleic acids. It is important for ATP synthesis, which we know is a great source of energy, part of NADP, that is a buffer, and this with pH balance, and this involves bone mineralization to achieve homeostasis. Phosphate is also involved as an enzyme activator for various enzymes, including hexokinase and phosphofructokinase. It's part of cellular signaling, which is important for any organ effects of different hormones. It's essential for your 2,3 diphosphoglycerate, which is important for oxygen dissociation from your hemoglobin. And it forms part of maintenance and structure, the structural components through hydroxyapatite of bone and teeth maintenance, as well as muscle function and nerve signaling. So this shows that it is integral to how our bodies function, and of course the complications will reveal why this is evident. So hypophosphatemia, there are various reference ranges, and obviously this is lab dependent, but it's generally accepted that hypophosphatemia is defined as a serum phosphate of less than 0.8 millimoles per liter with varying reference ranges. This is the reference range we use in our lab for adults, but obviously this will range, as I said, between different labs and methods that are used. It can be divided into mild, moderate, and severe cases through these levels. So generally accepted that a very severe hypophosphatemia would be less than 0.3 millimoles per liter. So why is this important? Why even talking about it? It's generally accepted that studies have shown that hypophosphatemia is an adverse prognostic marker. So in patients that are hospitalized, hypophosphatemia translates in many of these patients to increased hospital stay, mortality, quoted up to 30% mortality in some patients, hospitalized patients, post-operative complications, and obviously with increased hospital stay, there's cost and lower quality of life in general. But in the general population, patients that present with hypophosphatemia of moderate severity usually is less than 1% of the general population. And what we see in our context, obviously, in hospitals, 2 to 5% of hospitalized patients will have some degree of hypophosphatemia, more greatly so or more severe in patients that have alcohol abuse or severe sepsis, or patients that have advanced carcinoma, or patients that have had trauma. Just a few stats in ICU, where we expect the most patients that present with this, about 45% of patients, obviously with a high incidence in these critically ill patients. Patients with sepsis can even amount up to 26% of cases, and refeeding patients who are reinstituted with nutrition after states of depletion, 10% of cases, and with neoplastic diseases can range about 6% of cases. So the homeostasis of phosphate is a fine balance between your regulation of renal, intestinal, and bone. So all these organs really participating in creating a fine balance between this. The hormones responsible, the main hormones responsible for maintaining this balance are your parathyroid hormone, and this would be triggered by hypocalcemia or hyperphosphatemia state. But what this results in is that there is downregulation of your sodium phosphate transporters in your kidneys, and this resulting in renal phosphate loss. PTH, we know, is also responsible for 1-alpha hydroxylation that results in your calcitriol, so it upregulates that. And also PTH is involved in bone resorption with the resultant increase in calcium and phosphate where there is a need. Calcitriol, as we said, is induced by your PTH, your hypocalcemia and hypophosphatemia, and it's inhibited by your fibroblast growth factor 23 and hypophosphatemia and hypocalcemia. So what your calcitriol does is renally, it increases calcium absorption and also increases intestinal phosphate absorption through an increase or upregulation of your sodium phosphate channels. Your fibroblast growth factor 23, hypophosphatemia, and any FG, F23 dependent hypophosphatemia stimulates your PTH secretion. FG, F23 is produced by osteocytes and osteoblasts, and its mechanism of action is that it will decrease your sodium phosphate transporters, resulting in a phosphaturic state, and as well as decreasing alpha hydroxylation, which we elaborated earlier is important for calcitriol. So therefore, there will be a decrease in that. So this is just an image just to emphasize what we were saying. So there's this interplay between all these organs and all these hormones that really assist with regulation. And we know that extracellular phosphate being at the center of this, being filtered, reabsorbed in the kidneys, excreted, and obviously the bone also interacting in this with regards to formation and reabsorption. And there is fecal loss as well as renal phosphate excretion. And this also just to emphasize that the effect of the kidneys, or the importance of the kidneys in this regulation, is that 85% of phosphate is reabsorbed in the proximal tubule. So one can imagine if there's any defect or dysfunction of this, what can happen with regards to phosphate levels in the body. And this is just also to emphasize what we were saying, but I think we have covered that just to show the states in the body, or the body distribution with regards to phosphate. So how 85% exists as hydroxyapatite crystals, and 15% complexed with calcium to form calcium phosphate, and with less than 1% in the blood and extracellular fluid that is functional. So how would these patients present? So interesting thing about hypophosphatemia is that obviously it will vary depending on the duration of the deficiency, but also the severity, as we saw the different mild, moderate, and severe. So the issue about this is that most of the symptoms are very non-specific and can range from very non-specific symptoms, but also to multi-system involvement. And looking back on the functions of phosphate, one can imagine what can go wrong when the phosphate is quite low. So the resultant that these patients may have hemolysis, leukocyte dysfunction, so immune dysfunction, and platelet dysfunction as well. The impairment of tissue oxygenation, as it is important, through 2,3-DPHG. There's cardiac involvement as a result of decreased ATP energy for your cardiac muscle. So these patients may present with cardiomyopathies and ventricular arrhythmias, as well as ventricular hypertrophy that is also present in these patients. As a result of this decreased energy source, respiratory failure and muscle weakness failure. Neurologically, these patients may have altered mental state, encephalopathies, seizures, comas, and depending on the chronicity of the condition, in acute states, patients may present with proximal myopathy, rhabdomyolysis, dysphagia, and ileus. Chronic states would result in actually hospitalized have these conditions. There was a study done quite a while ago, but I thought it was important to mention because it is in our context, a study that was done in Tygerberg, and they wanted to look at the different causes of hypophosphatemia in a large academic hospital. So obviously these are quite sick patients that may be there. But it was just interesting to note the distribution in terms of causes and how these patients, what was most common. So as we said before, previously with the prevalence that in ICU, there's 45% in their cohort that they had hypophosphatemia and most likely quite severe. Patients that had refeeding, sepsis patients, about 6%. Patients that had malignancy, 6%, and post-operatively which also just highlights just how really just the importance of monitoring this analyte with regards to patients, especially post-procedure. We know alcohol withdrawal or diabetes also accounting for a lot. And there were other minor causes, but it's just to illustrate what we're saying, that these are patients that we really should look out for, make sure that we test. So I think this just highlights that as well. A bit more of an extensive list, but I think we have covered the people that we should really look out for. So with regards to hypophosphatemia, it's important to understand the mechanism of it, and that allows for us to be able to find a cause and hopefully request tests that will give us the answers and obviously institute the right treatment. With regards to the mechanisms, these include redistribution, which we will go into, a decrease in internal absorption, rather intestinal, increased urinary excretion, and patients that are undergoing dialysis. So with regards to redistribution, there is a shift from a shift based on different states that results in hypophosphatemia. So in patients that are, for example, being treated for DKA or hyperglycemic states, or any state that stimulates glycolysis, the increase in insulin or the administration of insulin will result in further transcellular shifts of phosphate, and this resulting in extracellular depletion. Therefore, these patients have hypophosphatemia. Refeeding syndrome, where also as a result of insulin-driven cellular uptake, where these patients were depleted before, and now it's basically a case where good goes bad, that you are really trying to help the patient, but unfortunately, there is that process where insulin drives the cellular uptake and results in hypophosphatemia. Something we see a lot as well in our hospitalized patients that are being ventilated, and any state that can cause respiratory alkalosis, and this resulting in glycolysis and an intracellular shift. We spoke about the importance of phosphate with regards to various enzymes. So as a result of glycolysis, there is an increased, in this state of alkalosis, there's increased phosphofructokinase activity that consumes more phosphate for ATP production. And then hungry bone syndrome, in these patients are post-parathyroidectomy. There's this cellular shift with these patients after the stimulus before. Now you've removed that hyperparathyroidism state, and there is shifts of electrolytes in that required. We mentioned sepsis, trauma, and burns, and this is as a result of a catecholamine surge that results in this hypophosphatemia. So I just wanted to go a bit more into detail with regards to sepsis. It is a busy slide, but I think because we see it so often, just to go more into details, to attribute what actually happens. So with regards to sepsis, as we said before, there's catecholamine increase and insulin increase, especially after we've instituted glucose, and there's increased cellular demand. So phosphate moves into cells to generate ATP, and therefore resulting in your hypophosphatemic state. We spoke about respiratory alkalosis. These patients are septic, therefore have increased breathing rates. This alkalotic state, as we said, stimulates that phosphofructokinase, therefore increasing glycolysis and phosphate trapping. And then there's the effect of cytokines on the renal function with regards to increasing renal loss of phosphate. There may be tubular dysfunction, and especially in patients perhaps that have large volume resuscitation, that they may be increased urinary phosphate excretion. And obviously, patients that are unwell, critically ill, there's reduced intake, poor nutrition, or even delayed feeding, and this is common in your ICU patients. We covered refeeding syndrome, so this is just to cover that. What we also see a lot. So when glycogen stores are utilized, there is decreased insulin production and increased glucagon secretion in states where obviously the patient is depleted, and now we are instituting resuscitation. So gluconeogenesis, where it's trying to increase your energy, so protein catabolism and mobilization of lipids as well. So there's protein, fats, mineral, and electrolyte and vitamin depletion with sodium and water intolerance. So when there is institution of energy or resuscitation with regards to nutrition, this increases insulin secretion, and this ultimately results in glucose uptake of potassium, magnesium, and phosphate, and increased utilization of thiamine, as it's important in this process. So these patients will result in hypokalemia, hypomagnesemia, hypophosphatemia, and your thiamine deficiency, as well as salt and water retention. We spoke about decreased intestinal absorptions in patients that are alcoholics, or patients that haven't been malnourished or have some sort of malabsorptive disorder, patients that are on phosphate binders, even patients that are taking antacids like aluminium and magnesium antacids, when these are bind to both ingested and secreted phosphate in the intestine, while niacin would promote phosphate loss by reducing your sodium phosphate channel expression in your kidneys. With regards to the other mechanism of increased urinary phosphate excretion, so causes such as primary hyperparathyroidism, we know that PTH is phosphaturic, vitamin D deficiency, intrinsic renal defects such as Fanconi, conditions that cause increased FGF23 secretion. There are genetic conditions in which FGF23 is increased, like your X-linked hypophosphatemic rickets, your tumor-induced osteomalacia in your heart, and intravenous iron administration. There are also effects of chemotherapeutic drugs and some antiretrovirals that will result in increased urinary phosphate excretion, and therefore resulting in hypophosphatemia. So I just wanted to cover, because we spoke about Fanconi syndrome. So this describes general dysfunction of your proximal tubules. We saw how much phosphate is reabsorbed in your proximal tubules, and this therefore a dysfunction and risk would result in hypophosphatemia, along with other analytes, so your amino acids, your glucose, your bicarb, your uric acid, and other solutes. So demonstrating, perhaps doing urine amino acid analysis would demonstrate excess excretion of these, but also what you would pick up biochemically, hypokalemia, glycosuria, and hypochloremic metabolic acidosis as well. The inherited and acquired causes of this Fanconi are definitely something to think about in patients that present with hypophosphatemia. We mentioned tumor-induced osteomalacia. So this is a rare syndrome, but it's characterized, or it's caused by an overproduction of your FGF23, and mostly by your mesenchymal tumors. So there's decreased maximum reabsorption of phosphate, resulting in renal phosphate wasting and therefore hypophosphatemia. And we spoke about this osteomalacia that results from decreased bone mineralization, and also as well as these patients presenting with myopathy as a result of your decreased muscle function. And in patients that are post-renal transplant, this is said to occur in 40 to 90% of patients 1 month after successful kidney transplant. The mechanism is not clearly understood, but it's reported to be likely due to the combination of your tertiary hyperparathyroidism and your chronically elevated FGF23 that results in this continued phosphate wasting post-transplant, as well as the combined effect of an increased incidence of vitamin D deficiency in this patient. So interestingly enough, the factors associated with a good response to a transplant, including your pre-transplant hyperparathyroidism, a living kidney donor, lower donor age, all are associated with an increased incidence of post-renal transplant hypophosphatemia. Another concept of that X-linked hypophosphatemia, which is a rare X-linked dominant inherited genetic disorder caused by your X gene mutation. And this mutation results in excess FGF23 production. As we spoke about the function of FG or how it operates, so there will be increased renal wasting of it, reduced calcitriol production, and this resulting in your chronic hypophosphatemia, and also impaired bone mineralization. As we saw, it is important for patients just for bone structure and maintenance of structure of your bone and teeth. So these patients will have osteomalacia, bone pain, teeth issues in your adults. So these patients, as we said, they will have hypophosphatemia, elevated or inappropriately normal FGF23. Unfortunately, as far as I know, FGF23 is not done in the country, which is unfortunate that we can't test for it, but these patients will also have low or normal calcitriol and increased ALP, and obviously there's genetic testing with regards to confirming the mutation. We spoke about iron infusion, intravenous iron infusion, which I thought was quite interesting because I was not really aware of it, but with intravenous iron infusion, the mechanism is that there is increased urinary phosphate excretion as a result of increased concentrations of FGF23. So it's said that there's a 3 to 6 fold increase within the first day of infusion. And also IV iron decreases your calcitriol and therefore reducing phosphate and calcium absorption intestinally, as well as secondary hyperparathyroidism. So the highest risk is said to be with your formulations of ferric carboxymaltase, your Ferinject, which is associated with a 47 to 75% compared to other preparations. And there are risk factors with regards to patients that receive iron that develop hypophosphatemia, so patients that had low baseline serum phosphate, had normal kidney function, because poor kidney function would reduce renal loss, severe iron deficiency, and lower bone weight and repeated doses of iron infusion. So something to just think about or to look out for in these patients that are receiving. This is just a diagram of genetic causes with regards to hypophosphatemia and how they would present biochemically. But as you can see, there's quite a whole array of them. But I think it's always important, at least what occurs commonly, for us to be able to address what occurs commonly. And when we have identified that we can't find suitable cause, to look further genetically and see what we find. We spoke about kidney replacement or dialysis with regards to hypophosphatemia. There are various mechanisms with that regard. During dialysis, there's rapid extracellular phosphate removal. So these patients may have hypophosphatemia, and there's inefficient replenishment from tissue stores. So the transfer of phosphate from intracellular back into extracellular space is slow. So therefore, a massive depletion of phosphate is seen by the end of dialysis. There's extensive use of phosphate binders. So when patients are on phosphate binders, the overuse or continued use of these binders during periods where there may be low dietary intake can result in hypophosphatemia. The low phosphate dialysate standard dialysis solutions which contain little or no phosphorus, therefore creating this gradient that allows for phosphorus to be driven out of the blood and obviously resulting in hypophosphatemia. There are nutritional factors with regards to refeeding syndrome. So patients starting peritoneal dialysis or undergoing intensive hemodialysis who have low protein or low phosphate intake can develop this, particularly when combined with high carbohydrate loads. There's intracellular shifting or rebound shifting of potassium after dialysis, and treatment of hyperparathyroidism, treatments that rapidly reduce the levels of PTH after, such as Sanocare, in dialysis patients can stop bone resorption, causing decrease in serum phosphate and therefore potential hypophosphatemia. These are just a few lists of treatments and medications to look out for with regards to causes of hypophosphatemia. On this list, as we mentioned, there are chemotherapeutic drugs that would cause drug-induced Fanconi syndrome, the use of amphotericin B or mannitol, which would cause pseudo-hypophosphatemic state, through osmotic diuresis, which also increase urinary phosphate excretion. There is, interestingly enough, your estrogen that downregulates sodium phosphate co-transporters in your proximal tubule, and various other conditions that would result in protein phosphate loss rather. So your states, we mentioned some of them, but celiac poisoning leading to respiratory acidosis that can also result in that. And there are other conditions as well, but you can see there's quite an array of drugs commonly used, your diuretics, your corticosteroids that increase urinary phosphate excretion, just to look out for that. So with regards to investigating your hypophosphatemia, so it's important to note that, as we said, there are lab-dependent reference ranges that are important to note the differences of. Also, interestingly, there is diurnal variation. So it's the lowest levels between 8 and 11 a.m. in the morning, and with the highest levels very early in the morning between 2 and 4 a.m. Interestingly as well, there is a postprandial reduction. That's why fasting is recommended, but obviously this is not always possible, or it's not something that you can always control in states of hospitalized patients or when you are investigating acutely. So this is more important for patients that have borderline hypophosphatemia, that you would like to confirm the finding, and therefore repeating it on a fasting sample would be optimal with regard to that. So obviously you have a patient that presents with hypophosphatemia or low phosphate results. It's important to note, we mentioned before that calcium may be complex to proteins, most often the albumin, but in patients with multiple myeloma and other lymphoproliferative disorders where there's an increase in paraproteins, these patients may have hypophosphatemia. And obviously, if you do your SPEP, your serum free light chains, and workup, you are able to find that. So this is a finding that you will find in these patients. We also spoke about patients that are on amphotericin B and mannitol. As a result of increased phosphate excretion, these patients will have hypophosphatemia. So to exclude that as the cause of what you are seeing, they also may be a transient hypophosphatemic state with regards, we spoke due to mechanism of, for example, refeeding, treating your DKA patient due to redistribution of your phosphate. Interestingly as well, severe leukocytosis is also postulated to decrease phosphate with effect of continued metabolism of leukocytes. Obviously, interpretation of your phosphate, which is what we will do with regards to ordering tests, ordering a CMP and ALP, seeing how you're correlating this with your PTH and vitamin D levels. Blood gas is useful with regards to alkalosis, as we shown, the redistribution mechanism that results in that, and also urinary phosphate or tubular maximum reabsorption of phosphate. And you consider FGF23 if there is renal wasting, as we said before, that it's not currently being tested in the country with regards to that, but it's just something to mechanism to think at the back of your mind. But at the end of the day, also in patients that are having hypophosphatemia on your biochemistry, but obviously you have to correlate this clinically with your symptoms. As we said, patients may range from asymptomatic states to multi-organ issues. But if in patients that you do not have what you're seeing biochemically is not correlating with what you would expect, then the advice is obviously to repeat it and to confirm it and to exclude pseudohypophosphatemia as a cause. So with regards to renal handling, we saw the importance of the kidneys with regards to regulating phosphate. So this tubular maximum reabsorption calculation that allows the preferred index for your phosphate handling. It requires a fasting paired serum and urine sample. And this calculation where you measure tubular reabsorption of your phosphate. So that is the calculation that gets done. If your tubular reabsorption of phosphate is less than 0.86, then you want to do this calculation, which is your tubular maximum. So it calculates the maximum capacity of your kidneys to be able to reabsorb phosphate. And that is the calculation that you would use. And if it is greater than 0.86, then you would use the formulas shown in the block on your right-hand side, and that will use those to calculate. So based on what these are the reference ranges at the bottom for your calculation. So this is just an example of what how you would calculate. So a patient presents with a phosphate of 0.5 and 390, urine phosphate of 18, and urine creatinine of 6. And this, according to that calculation that we noted above, you're able to multiply this, and this gives you TRP of 0.40. And then this step to calculate your maximum reabsorption per glomerular filtrate is to actually then multiply it with your phosphate concentration, and therefore you get 0.8. So generally, in your male or female patients, those are the reference ranges as we see at the bottom. But this is obviously quite low. So this illustrates that there is inappropriate reabsorption of phosphate through the kidneys, and therefore this supports the diagnosis of renal phosphate wasting. And this allows you to have that as a cause, that you know that the kidneys are not maintaining phosphate homeostasis as they should. So just to consolidate what we said, you have these patients that have low phosphate, and then they have this low tubular maximum reabsorption per glomerular filtrate. So as we said in that previous example, that would be renal wasting, and therefore you are looking at causes, PTH-related causes, FGF23 or tubular pathology. And then if you have a normal or a high maximum reabsorption, then this means that there is appropriate renal reabsorption, and therefore you will look at other causes other than renal handling as a cause for your hypophosphatemia. So you will look at redistribution of poor intake of vitamin D deficiency as causes. So as we said, you interpreted with your CNP, obviously your PTH, your vitamin D, very important. And I put that there, consider it, but like I said, we do not offer it, but it's something to have in mind, knowing the mechanism of it, what could cause. And just to say, repeating after a correction of acute illness is important in patients that are borderline, have this borderline hypophosphatemia that you want to. Also, to investigate your renal handling is through fractional excretion of phosphate. So this measures how by the renal handling by calculating the percentage of filtered phosphate excreted in the urine. It will differentiate your renal phosphate testing from other causes. 5% is used as a threshold, so less than this would mean that this is appropriate in states of hypophosphatemia. Therefore, the body is conserving phosphate, and that is seen as appropriate. So this is useful as well in illustrating. There's also a 24-hour urine phosphate excretion that one can do. So in states where, as we said, perhaps a fractional excretion of less than 5% and a phosphate excretion of less than 100 milligrams, then this is considered appropriate in appropriately low in renal phosphate excretion. And then if it's greater than 100 milligrams or with a fractional excretion of greater or equal to 5%, this would indicate your renal phosphate wasting, and therefore one should look at all the causes we spoke about before with regards to phosphaturic hormones. So this is just a diagram to illustrate what we were talking about. So you have the different your fractional excretion or 24 phosphate urinary phosphate excretion. So if it's appropriately low kidney phosphate excretion, then you're considering your other causes, so not renal, but your GI absorption issues or the transcellular shifts, something to consider. In patients that are having very high renal excretion, you notice that there is wasting, and therefore you would do your PTH, and that will obviously give you an idea where to look at if it is increased, normal or increased, looking at vitamin D deficiency as a common cause. And unfortunately, as we said, FGF23 is not done in the country, but if you have a decreased PTH, and these are the conditions to look for with regards to investigation. So with regards to treatment, obviously treating the underlying cause is important. Based on the severity of your hypophosphatemia, oral phosphate can be mild to moderate, and IV phosphate is severe or significant. Oral phosphate is generally given 30 to 60 millimoles per day, divided doses, with IV phosphate indicated, as we said, in very severe or symptomatic cases. Typical ICU regime would be between 0.08 to 0.16 millimoles per kilogram over 6 hours. It's important to choose the preparation of your phosphate, sodium versus potassium phosphate, based on your potassium status. And obviously, in patients that you are giving replacement, they should be continuous cardiac and biochemical monitoring. So this is just an example of phosphate a supplementation protocol based on severity. As you can see, the severity and how it increases with weight. Just important to note that if patients have potassium less than 4, it's better to use potassium phosphate instead, and if the patient's potassium is greater than 4, to use sodium phosphorus. So sodium phosphate injection provides the same phosphate content as potassium phosphate. So depending on your potassium status, you would choose the right formulation. There are complications to your treatment or institution of your replacement of your phosphate. So they may be calcium phosphate precipitation. So when phosphate is given, your serum phosphate will obviously rise rapidly in doses. This forms binds with ionized calcium, forming calcium phosphate complexes, and this can result in this calcium phosphate precipitation. There's also metastatic calcification. So in patients that have persistently high phosphate, there may be precipitation of calcium phosphate salts in normal tissues. This causes tissue dysfunction. And in patients that are they may have acute phosphate nephropathy. This is associated with a large phosphate dose or load that results in calcium phosphate crystal deposition in the kidneys. So this leads to tubular issues, obstruction. They may also cause direct tubular injury, which is something to consider. And the outcome would be that these patients may receive an acute kidney injury. Hyperkalemia, more specifically with your potassium phosphate, may result in arrhythmias with regards to that significant potassium load. And this would be obviously quite dangerous in patients that have renal impairment or have use of concomitant potassium sparing drugs that are there. And the effect is that these patients obviously have conduction abnormalities and so on. And then with regards to secondary hyperparathyroidism in patients that are having chronic therapy. So the chronic hyperphosphatemia would reduce ionized calcium via binding, as we said before, but also decreasing your calcitriol synthesis. And this phosphate suppresses your alpha-1 hydroxylation and therefore decreasing that. Both stimulate your PTH, so the long-term effect would be that there would be a parathyroid hyperplasia and bone resorption, giving obviously a bone weakening picture. This is also just a table to just give some of the side effects with regards to the different management strategies with regards to the cause of hypophosphatemia, so and how to manage them and what to do with those in those cases, depending on the cause. So in conclusion, hypophosphatemia is common, but maybe quite under-recognized, or perhaps not something that is always clear how to go about forward. But looking at the different mechanisms, one can try and figure out what the cause of low phosphate state is. And it is usually multifactorial, meaning, looking at how the body and understanding of the physiology and the different organs involved, and obviously correlating that with clinical findings, one can try find a diagnosis. In acute settings, it's important to consider redistribution as a cause. Give an extensive list of the different causes of that, but it's sepsis, or respiratory illnesses, as we said, we see a lot of mechanically ventilated patients, and obviously that is something that we should. Part of the renal phosphate handling is central to diagnosis, so being able to exclude renal wasting is important to be able to find. Thank you very much for your attention.
Thank you, Karabo. That's quite a very good master's kind of lecture. I never thought phosphate could actually consume so much time. I think because we hardly spend enough time in ICU when you look at hypophosphatemia, we just go to place. But obviously, I think it's clear from your lecture that whatever we see as a complication of patient with chronic kidney disease is actually phosphate, especially cardiovascular, from the LVH to the valve to coronary artery calcifications to endless. So hypophosphatemia probably is quite a very crucial. That's on the high part. So that's obviously on the low side of it. Obviously, you do see quite a lot of other effects. So for me, I think one of the very, but also I think one of the things, look at the pharmacy part of it, I think normally we really struggle to have medication to replace phosphate. And I remember that a couple of times, I don't know, it's never been taken as serious as should be. Most of the time we have to use like enemas just to replace phosphate because there's no drugs available. Either they come as a phosphate or chloride or others, but there's really no pure phosphate itself for replacement. Am I wrong? The question is why? When it's really so important compound in our body, isn't it?
All right, then it's to be manufactured.
And we have sodium phosphate or potassium phosphate.
We have
Potassium, that's what I was thinking as well.
So it is difficult at the moment because the specific products are in and out, and then we also have, I think, calcium phosphate. Huh?
Yeah.
Yes. So it's either that one or the potassium phosphate, but because both of them are intermittent and sometimes one is out, and then it's difficult, as Dr. Karabo indicated, that if you have a high potassium level, the potassium phosphate is not always great. So some resort to enemas, and because of the high phosphate content.
There's some in government. If they're in government and we had a shortage of phosphate, we would encourage our patients to drink Coke. I don't know.
Well, okay.
It's apparently very high in phosphate.
Yeah.
The problem with the Coke, I think it contains a lot of
Well,
people say it's a little bit add values, but in desperate measures. So yeah, now I understand the frustration with the pharmaceutical.
But I mean, phosphate is very abundant. I mean, they use as fertilizers, they use all over the place. So we shouldn't be struggling.
the same.
That's what I'm saying, but you could
I
kind
will
of,
add that as an addendum to the lecture.
the question of being able to manufacture it, I mean, if it's kind of quite available.
Yeah, so I see here on up to date, which is interesting to know, is that 1 cup of skim milk contains exactly the same amount of phosphate as tablet preparations. So you can see, so 1 cup of skimmed milk gives you exactly the same concentration as all these tablets and preparations. So that's why there's actually a cheap option. Then
why skimmed milk? Yeah.
I'm not sure. You'll have to ask the dietitians about it. But yeah.
But it's quite an extensive presentation, I must say. Well done. I think I need to, if you need to listen to this podcast, because you just get lost in between, because it's like got some lovely rich details. I think we never really spent time even up during our Mmed.
More into the presentation.
I think you should be an expert in the phosphate. Online, Dr. Kohli, anybody out there? Any questions?
Press the people so in case I can.
Good morning. No question from my side. Yeah, I think it's also a bit of challenge sometimes with the oral preparation. I know there was a time they had a sandose phosphate, which was very effective, but
yes,
I think it's off the shelf again. Sometimes we also resort to enema, just like you said. But in situations where diarrhea is also one of the causes, it becomes a bit problematic. But all in all, is It's a great presentation and it's a topical issue. Thank you.
And I mean, we also seen a lot of patients with hypophosphatemia that actually present with a syncope, seizures, syncope, first episode. We see quite a lot, but also in children. I mean, children, because they use phosphate for growth, and sometimes it's very low, they tend to come really quite these recurrent seizures also. So yeah, so phosphate really a very vital obvious mineral in our bodies, you know. So I think, but this is got good presentation. Anyone else with question, comment? Nicole? Nikki, any question?
Just another thing while you were doing, I'm also having a look here and see. So they actually say that IV phosphate is actually quite dangerous, and we probably give it also incorrectly, because if you give it, if you give it with calcium containing fluids, and a lot of our patients on bringers lactate, and the nurses just give calcium phosphate, it can actually give you, so which doesn't work. So they actually recommend, this is especially for us for ICU, is they recommend that you give it in severe hypophosphatemia with symptoms. You have to recheck the calcium levels, I think every 2 hours after giving it. As soon as the calcium of the phosphate levels are up, you have to switch to oral containing phosphates, and they actually recommend giving oral phosphate above giving IV.
Which we do have abundance of in the pharmacy.
Because
I wanted to ask the phosphate syrup.
Yeah.
We always like.
Yeah.
What is it? What preparation is it? It's phosphate in?
Potassium or
So you get the no, I'll have to just check what is exactly the salt compound, but you get a potassium syrup and then you get a phosphate syrup. So it's two different ones. So the potassium chloride is a different one and the phosphate syrup is a different one. So it's also a salt compound, but because you create the mixture, it results in a specific mole concentration that we convert to a mole that you then take. So I'll just make sure about the salt compound. I can't remember now exactly. And then I'll let you know. But yeah, we do have that one.
You've got tablets.
No, we use powder.
Powder.
Yeah. So it's a mixture of two different types of phosphate that you add together with then the liquid that you dissolve it into. It's like dehydrogen, potassium, phosphate, and the other one I can't exactly remember. I'll post the exact compound names on the group today. Yeah.
And another thing was during ECCM they presented things. They actually presented calcium phosphate and magnesium. So, and they looked at. So we do it briefly. Once in a while, you do a phosphate level as part of which is actually incredible. Because the question is, if you have a low phosphate and you treat it, when should you retreat it? Because what we try to do is we do a phosphate and then a couple of days later you do it as part of a CMP because and so I think we
in the
ward.
So what I see, I tend to do phosphate every day. In the ward, I tend to do every second day. I quite do do phosphate quite a lot. The CMP because again, it's got a lot of prognostic implication, patient recovery and outcomes, and especially when you're looking with the cases that come in and with magnesium, because magnesium, phosphate, and calcium is really quite very essential, and because the tests are not done together, you can't do them as individual. So by default, because my focus always with magnesium, there is
also has a cost implication.
Yes,
I mean,
look,
what
it's 500 rand, around 500 or
what is the
CMP
cost for a phosphate?
500 rand.
Sorry?
CMP.
around there. Before it was 500. I think it should be cheaper now. Not so sure.
Yeah. So it comes with a cost implication. I mean, it's every test that you test for is.
Yeah, but also, I mean, the price you pay for not testing, it then means prolonged hospital stay. So the questions that I think Depends obviously on your diagnosis that the patient get admitted. If patient got respiratory issues, phosphate need to be done more frequent, and calcium magnesium phosphate. The reason that because it helps in your respiratory muscles, and obviously if your calcium's low, you have problems, dysrhythmia. If your magnesium's low, you have issues. There's something as a phosphate, respiratory muscle weaknesses. So it's
but if it's normal,
well, if it's normal, then repeat the second day. So, but it's very essential that you have to do it, because the question that you will not be able to replace your potassium if you don't know your magnesium levels. It's very important. So wheat being phosphate by default. And if someone's on Lasix, phosphate must be done, CMP must be done every day. Because again, that affects how you actually catch up with potassium replacement. Because of the magnesium play a role in potassium sodium pump. That's how essentially it's. There's a very principle in critical care that you actually have to have CMP done every day. It shouldn't be alternative. It should be everyday CMP. Because I mean that single thing. I mean we always know that if you're potassium 2.3, that patient spend one extra day in ICU, and that's 22,000 rand a day. And in terms of high care, it's about 12,000 rand. So you look at 500 rand beside 12,000 rand. So the questions that I think that's why discovery for principal ICU. There's certain condition that actually you have to do CMP twice a day, morning and the evening, to have a look at your actually your correction levels.
Plasma exchange.
Yeah, plasma exchange, especially calcium. Most of the patients actually go into cardiac arrest if you don't resolve the phosphate and calcium because they get removed by dialysis. So, costs, that is a different story. The question of how much do you actually spend in terms of to prevent cost? Does it work for you to set 500 rand, and then in long term, you actually have more. The same thing as PCT. Done?
I'm just gonna fix it.
Yeah, because Discovery have argued with me about